Hello everyone, and welcome to the final webinar of the day, engaging with and the public to promote ethical drug policy. We're joined by lots of people today, so thank you very much to everyone for joining. You're all extremely welcome. The first, if you're more comfortable with Russian than English, you can use the interpretation option at the bottom of your screen and select the Russian channel, and you can also switch off the English audio if it's easier to hear. A big thank you to Maria and Xenia, who are translating today, and also to Eliza, who's translating questions behind the scenes. Use Twitter, we will be using the hashtag ethical drug policy if you want to carry on the discussion after the webinar or during the webinar, which is being posted in the chat shortly. My name is Adam Holland. I'm a public health doctor in the UK and a researcher at the University of Bristol. I'm very lucky to be chairing the panel today with help from Dr. Emily Crick, who is also from the University of Bristol. This webinar has been organised for the 2020 European Harm Reduction Conference in collaboration with the University of Bristol in the UK and the Harm Reduction Journal. So a big thank you to everyone who's been involved with organising the conference, especially for everyone for relation, and thank you for hosting this session today. We're extremely lucky to be joined by 6 brilliant panellists who need no introduction, but will be posting their details in the chat shortly. They have backgrounds working in drug policy academia, international advocacy for the police, the Portuguese Dissuasion Commission, and for treatment services. They're going to be discussing what a more ethical approach to drugs might look like, how we can engage with policymakers who can make changes to our approach, the public who hold them to account to do so. A common criticism, which has been talked about a lot in the earlier webinar today, is that much of contemporary drug policy is not on evidence. And this is clearly incredibly important. However, as well as empirical investigation, so too an ethical analysis is important. And this is because it's necessary for us to think about what the aims of drug policy are. What are we looking for evidence of, and what measures are ethically justified to meet those aims? For us, the attendees of a conference with harm reduction in the title, this might seem very obvious. Aims of drug policy could be to reduce harm and to uphold the rights of people who use drugs to liberty and health, regardless of their drug use. However, unfortunately, this view is not shared by everyone. In many countries around the world, and although in many places great strides have been taken, in many other places, unfortunately, decisions still seem to be made based on the idea that drug use should be punished, because using those drugs which are arbitrarily illegal is immoral, and there is something deficient about the people who are doing so. Reducing harm and whether there is evidence that an approach does this might be a secondary consideration. This ideology, which is driving punitive drug policy for many, seems to be based on a circular argument. Some drugs should be illegal and their use should be punished because using them is immoral, and using them is immoral because it is illegal. The circularity of this argument means that it is very difficult to challenge for those who hold it with rational arguments. In general, how do we challenge the ideology which is driving punitive drug policy and the stigma that emanates from it? What has been their experience when doing so in the past, and what can we do in the future? Importantly, what do they think a more ethical approach to drugs looks like? Now, obviously, that's an awful lot for them to talk about in 9 minutes, so all the panelists won't be covering all of these points. Hopefully going to bring forward some interesting points for us to ruminate on, and there will be the opportunity to ask questions. So during the panelist presentations, you can ask questions using the Q&A function at the bottom of the screen, and Emily will be fielding as many of them as we have time for at the end of the session. Feel free to ask questions anonymously, or alternatively, if you include your post and your affiliation, we'll share that when we ask the question. Please indicate in the question if you would like to ask one person in particular a question, or if you'd like to ask the whole panel. And you can ask questions in English or in Russian. Finally, just before we hand over to the panel, a few quick words on what's prompted this webinar today. So in the interest of trying to engage with those members of the public who have not been exposed to some of the arguments for alternative approaches to drug policy, I had to go out making a short film using an example to demonstrate some of the problems with the criminal justice approach to drugs. To anyone that watches it, it might be fairly obvious that this was my first attempt making a film, and apologies for some of the clunky. But I hope that it at least partially does justice to the 14 amazing contributors, academics, advocates, police officers, and practitioners who very kindly gave their time, and some of whom are in the panel today. The film examines some of the misconceptions fueling criminal justice-focused policy, Much of the content is probably not new to those who work in this field and to the people at this conference. However, it's hoped that the film might be useful for you if you're trying to engage with groups of policymakers or professionals, or indeed the public in the future. Although the film focuses on the UK, much of the content I hope and I think is obviously relevant for other countries as well. So I hope it is useful there too. The premiere of the film on YouTube is going to be at 4:45 UK time or 5:45 Central European time. And there'll be a live chat function if you want to talk about the film or indeed if you want to talk about anything else. So shortly, a link to the film premiere will be published in the chat, along with a preprint of a commentary on the film and critical analysis of contemporary drug policy, which is forthcoming in the Harm Reduction Journal. So that is more than enough of me, and it's a pleasure to hand you over to our first panelist today. So our first panelist is Professor David Nutt. He is a professor of neuropsychopharmacology at College London. He is the former chair of the UK Home Office Advisory Council on the Misuse of Drugs. He's the author of Drugs Without the Hot Air, and he's chair of Drug Science, which is an independent scientific advisory body on drugs. So a big thank you to Professor Nutt.
Well, thank you very much. It's a delight to be talking at this impressive meeting. And I'm going to talk from the perspective of drug science and share with you the way drug science has been thinking about drug policies over the last decade since we set it up. And we will argue that there are 6 major flaws in current criminal punishment-based drugs policies. I'm not going to go through all of them, I haven't got time, but I'm going to focus on the 3 in red here. The first 2 essentially argue that what we do is immoral because there's a bias in the decisions about which drugs are controlled, and a decision is made to put punishment above harm reduction, which is also a moral choice. And then at the end, I'm going to talk very briefly about one of the less well-known and less articulated issues relating to current drug policy, whereas the detrimental impact, the vast impediment it presents to treatment and research. So you're probably all familiar with this graph. This is the MCDA of looking at the 16 different ways in which drugs can do harm. It was really the flagship output of drug science when we started. And it shows really very clearly that drugs differ enormously in relation to their harm scales, with blue being the harm to the user, red being the harm to others, and the total being the total. You can see here alcohol is at the top, followed by heroin and crack cocaine, and drugs like LSD and magic mushrooms are down here. So there's an enormous discrepancy between the harms of drugs when you assess them in a very thorough way, and then you can reflect as a correlation between the harms of drugs and their position in relation to the Misuse of Drugs Act. So whether they're unclassified like alcohol, whether class C, B, or A. You don't need to be a statistician to know that there is no correlation between the harms of drugs and their position in the Misuse of Drugs Act. And that is a hugely worrying finding, because it tells you categorically the Misuse of Drugs Act is not based on evidence, and yet it should be. It is supposed to be the best evidence we have of harms. And the UK Misuse of Drugs Act is very similar to the UN Conventions on Drugs, and they have produced enormous problems for people who would like access to drugs which are controlled, like opioids for pain control, like cannabis. Still only about 20 countries in the world have medical cannabis. As far as I know, no countries in the world have, as nations, formally allow psychedelics as medicines, although some of the Latin American countries do allow indigenous production of ayahuasca. MDMA, I think, is illegal in most of the world, and that's all because they're Schedule 1 controlled drugs under the UN schedules. And the scheduling of these drugs is probably the worst censorship of research in the history of the world, because as you see here, it has had an enormously detrimental effect. So here I'm looking at the 2 psychedelics, LSD in blue and psilocybin in red. You can see the number of publications each year following the release of LSD to the research community by Sandow in about 1952, and the release of psilocybin by Sandow as a medicine in the late 1950s. And then you can see when the ban came in. For a couple of years, people were still writing up work they'd done previously, but then research disappeared. And it disappeared for two reasons. One was that no governments would fund the research since after the drugs were made illegal, on the grounds that working with illegal drugs was somehow condoning recreational use. And the second reason was that the regulations are so complex and difficult that in reality they censor research. And the same was interestingly true about cannabis. We've now in recent years seen a resurgence of research in cannabis particularly because of the American states and a few countries that have made it a medicine. But again, the 1971 UN Convention was very destructive to research on cannabis. And I think one of the ethical issues that we should be discussing today is very much this, because I believe this is a deliberate ploy. I believe there was a significant drive, unspoken drive, to stop people learning the truth about these drugs by making it very difficult for them to work. And that's another of the circular arguments that Adam raised originally. If you can't research these drugs, then there's no way you can discover that their banning was based on false premises about their harm. And still many people today believe that psychedelics are very addictive, which they're not, and that cannabis is a dangerous drug, which of course it isn't. And I just want to, sorry, that's just a blow up of that one. And going back to the question of psychedelics, particularly LSD, there was an enormous amount of data, 1,000 clinical papers on the value of LSD, particularly in psychiatry, until it was banned. 130 NIH grants were funded to research LSD. It was seen as one of the great revolutions in mind medicine, in neuroscience, and in psychiatry. And the outputs were very positive. And yet it was banned purely for political reasons, although that was masqueraded as harm. Now here I just want to sort of show you one impact of that. So this is a recent retrospective meta-analysis of the 6 trials of LSD and alcoholism that were conducted under by the US government before the drug was banned. And you see, if you look on the right-hand side, the effect size here is about 1. And that makes LSD, and it's been given here just in 1 or 2 doses, is more powerful than any treatment we've had before or since for alcoholism. And you might estimate that since it was banned in '67, in the intervening 50 years, probably 100 million people worldwide have died prematurely from alcohol problems. And even if LSD only helped 10% of them, that would be 10 million lives saved. And when you think, what has the ban done to reduce recreational use? How many lives has it saved through recreational use? The answer might be 10, not 10 million. And that, I think, emphasizes the enormous dishonesty of this, of perpetuating this particular form of restriction. And just as a final slide, we've been thinking a lot of what we should do in the UK. We think part of the problem is that drug policy in the UK is based in the Home Office, which tends to see everything as being to do with policing. We should move it to the Department of Health and Social Services. We should reschedule all drugs to Schedule 2 so that researchers who want to work with them can access them. That would have no impact whatsoever on the threat of diversion or recreational use. Of course, we should have testing. We should have safe injecting rooms. We should roll out naloxone to help deal with the rising expansion of fentanyls. And this is more a personal point of mine, not a drug science policy point. We should actually regulate access to most drugs that are less harmful than alcohol in order to the user than alcohol, in order to get away from this inequity and immorality that we currently have today. So thank you very much.
That's brilliant. Thank you so much, Professor Nutt, for joining us today. Lots to talk about there. And if anyone has any questions, please do start asking them using the Q&A function at the bottom of your screen. So now, with great pleasure, I'm going to introduce Anne Fordham, who is the Executive Director of the International Drug Policy Consortium and the Chair of the Strategic Advisory Group for the United Nations. Over to you.
Thanks so much, Adam, and Yes, it's really great to be part of this panel. Thanks for bringing us together, and thanks to Correlation for hosting us as part of their online conference. Yeah, it's given me quite a lot of food for thought in preparing for this discussion, in fact. And of course, you know, from IDPC's perspective and from, you know, drug policy reform in general, we're pretty much united that drug policies based in prohibition have failed. Policies based on punishment and repression have caused a huge amount of harm, and it's increasingly acknowledged that policy harms far outweigh the harms of drugs themselves. And of course, you know, my sense was and is that drug policy is deeply unethical, but it was really interesting to think through that aspect of it, and I very much hope that we'll come back to that discussion in the Q&A, because it is a complex discussion and definitely merits further thought around what an ethical drug policy looks like. You know, the global drug control regime has been established on the basis of drugs as a moral evil, and policies to date overwhelmingly have been driven by this utopian goal that we want to achieve a drug-free world. And the supposed morally correct intention of punitive drug control was considered more important than the impact or the outcomes of drug policies themselves. And this framing, you know, has really been solidified by the US government over decades, especially under Nixon, who is, you know, widely credited with coining the phrase war on drugs. And it's led to this ideology that, you know, through policies, we have to send the right message about drugs. And this has pervaded drug policy making to this day. Governments have an obsession, for example, with the level of drug consumption in society, and pay far less attention to other harms that are in fact driven by policy outcomes, or in fact even refuse to accept that these potentially are policy harms. So for example, the number of overdose deaths, HIV and hepatitis prevalence amongst people who inject drugs, you know, the violence, the insecurity associated with government responses to the drug market, you know, widespread corruption that is also driven by the drug market. And for example, in considering important reforms such as removing criminal sanctions for drug use, governments will often be overly concerned with what message this reform will send to the public and young people about drug use, rather than being concerned about how this will remove a huge structural barrier and driver of harm, and how there's an urgent need to shift away from damaging policies. I think it's important to say that the picture is shifting and support for reform is growing. In part, I think it's important that you know, the understanding of the roots of drug prohibition and the interest that these narratives and policies have served has been an important component in challenging the dominant approach. So for example, increasing attention has been paid to the disproportionate impact of drug law enforcement on people of colour. You know, in the UK, Black people are 8 times more likely to be stopped and searched than white people. In the US, Black people are incarcerated at 5 times the rate of white people, and 50% of them are incarcerated for drugs. This is not an unintended consequence of drug policy. This is by design. The roots of the drug control system are deeply racist and imperialistic. You know, if you look back at the records around international conferences, early international conferences on drug control, these featured predominantly white male negotiators who, while smoking cigars and drinking cognac or brandy, decided that psychoactive plants all over the world used by Black and brown people for traditional use, for medicinal use, for sacramental use, for cultural use should be banned. And interestingly, you know, any attempts to ban alcohol were resisted very strongly by the same governments, the European wine producing countries that agreed all these other substances you know, used mostly in the global south should be banned. Stigmatizing certain substances and making their use seem deviant has served to dehumanize and demonize the communities that use them. People of color, migrants, political dissidents. This has been a very useful strategy that has been employed by governments the world over. Unpacking and making visible the underlying rationale for drug control, I think, has been very important for us as we consider reforms and challenge, the underpinnings of these approaches. So I think it's incumbent upon us to really talk about that a lot more, unpack that, understand what is really behind drug control and whose interests it has served. Finally, just to end on this question of ethical drug policy, I think there's so much to talk about here, and I'm sort of never really studied the question of ethics before, so I think I'll leave that to others. But I think in terms of some basic principles, a document that has had a lot of work from the drug policy reform, collective input from drug policy reform actors, has been the development of the international guidelines on human rights and drug policy. And I think it provides a very useful framework for thinking about some of the principles on which ethical drug policy should be based. The foundational principles in the guidelines include human dignity, that no law, policy or practice should have the effect of undermining or violating the dignity of any person or group of persons. Equality and non-discrimination is a second principle, that we are all equal before the law and entitled to the equal benefit of the law, including the enjoyment of all human rights without discrimination. The third foundational principle, which is so important, is meaningful participation, the right to participate in the decisions that affect people's lives. The principle of nothing about us without us. Those white male negotiators sitting in dark rooms, did they engage indigenous peoples in asking them what their views were on the prohibition of the plants that were sacred to them? Also, I think under meaningful participation is the right to informed consent. So, the current use of forced treatment, that many people who use drugs around the world currently experience, is incredibly problematic in that regard. And the fourth foundational principle is the universality and independence of rights, that human rights are universal and inalienable, and a person does not, through getting involved with drugs, forfeit their rights. And finally, a key principle of ethics, I guess, that we must adhere to in designing drug policies is the principle of do no harm. Drug policies are driving a huge amount of harm, as we know, greater harm than the drugs themselves. And I think also, just to reflect on what Professor Nutt said, it is immoral to continue down the route that we've currently been going down in terms of punitive drug control policies. Now we know that they lead to so many, so much damage, violations of rights, and it's immoral to waste resources on policies that simply are not working. So yeah, it's definitely time to rethink drug policies. Thanks.
Brilliant, thanks so much, Anne. That was really interesting. And yes, please, everyone, you keep asking questions at the bottom, and we will send Anne at the end of the session. So on to our next panelist, Dr. Magdalena Harris. Magdalena is a qualitative researcher, an ex-injector, and an associate professor at the London School of Hygiene and Tropical Medicine. He conducts participatory research with people who inject drugs with a focus on reducing health harms related to social exclusion and to illicit drug use. Over to you, Magdalena.
Cool, thanks, Adam. I'm just going to share my screen here. So give me a second to sort this out. Okay. All right, so it's a huge pleasure to be here at the launch of Adam's timely and important film, and with such an illustrious set of fellow panelists. And Adam has given us a huge amount of questions to think with, which actually sort of had me a bit flummoxed for a while, where to start. Now, one of these, he's asked us to think about what an ethical drug policy means to us. and also pose the question of how we challenge the ideology of drug use as a moral that drives punitive drug policy. And this really made me think about, is the criminal justice approach the only punitive drug policy? And I'm very wary of us just taking on what is seen as a benign alternative, which is the medical model. So I guess in this talk, and I think, you know, Anne illustrated some of the difficulties of this, talking about forced treatment in the name of treatment, in the name of the medical model. But also, I think that focusing on a medical model is problematic in that it very narrowly focuses how we might conceive of the problem and how we might intervene. And so in this really short talk, I want to focus more on structural issues and structural solutions. And I'm going to, I guess, move away from the macro focus of David and Anne to a more sort of micro London-based focus with my work with people who inject drugs, and some of the small and pragmatic actions that I've done to try and change policy within the constraints of criminalisation. And as Anne said, you know, I think fundamental to an ethical drug policy is that it is participatory, that it is informed by the needs and expertise of people who use drugs, and that is collaboratively developed with them. So I'm just going to provide some research examples here. So this is based on my current study with called Care and Prevent, and we were very lucky to have 455 people complete quite an onerous survey, and I also conducted in-depth interviews with 36 of them. And I'm just putting the slide up to illustrate, you know, the marginalisation of this population, and it's often the most visible population of people who are using drugs and can be taken to be seen as, you know, where the drug problem resides. Whereas, of course, we know that drug use is throughout all strata of society. It is just the most marginalised that are more visible and sort of encapsulate for us what a drug problem is. Now, of the 455 people here, the vast majority had experience of street homelessness. So nearly 80% had rough experience sleeping on the street for a median duration of 4 years. And really what I want to highlight here is the high proportion of people who had what are essentially preventable injecting related conditions, skin and soft tissue infections such as abscesses and cellulitis. And of those, a large amount, 30% of the entire sample were hospitalised for what are essentially preventable conditions. So what's going on here? You know, what are the policy and risk environments that we can potentially intervene in, even in the context of criminalisation? And here I want to point out, you know, the risk caused by policy and structural environments. So for our population, criminalisation coupled with zero tolerance for drug use hospital policies often led to urgent semi-public injecting. Now, it was urgent because it's criminalised, and there's a huge amount of problems of urgent rushed injecting that's going to cause venous damage, there'll be blood in the environment, etc. So Gary gives an illustration of rushing because he's scared there'll be cops behind the door in a public toilet. Now, Gary was sort of lucky to even get access to a public toilet. Austerity policies have seen over 600 public toilets close in the last 10 years in the UK. And this has led to quite a shocking environmental constraint that has really impacted upon the participants that I've worked with. That is lack of clean water to prepare an injection with. So Eddie here, he says there was no water. I had to use a bit of saliva. I got the worst infection of my life. I nearly died. I was in hospital for nearly 3 months. Saliva contains a huge amount of bacteria. Not having access to clean water is obviously a health harm. Now, Adam talked about countering stigma, countering prejudice and ideology around immorality. That linked to this is also this idea that people who inject drugs don't care, that they don't care about their health, that, oh, they will use saliva or a puddle water because they can't be bothered going to the nearest pharmacy or whatever. Now, I really would strongly dispute this. And I think, you know, the quote from James is very indicative, and it's a very poignant example of somebody taking great care in a situation of incredible constraint to try and make his water clean. He talks about trying to filter puddle water through alcohol sterets to get the dirt out of the water, you know, which is a really shocking example. Now, I'm not going to go through this slide at all because, but what I wanted, it's up there to illustrate that to understand what was going on with water for injection, why it wasn't in injecting packs, I had to sort of delve into the minutiae of legislation around water for injection and how problematic that is, and that indeed there is a history there, and that's all written up if people are interested. But Adam wanted us to talk about what we've done to try and advocate for change, and these are very small steps, but I think it's important to think about being able to make small changes, you know, when big ones seem to be too hard, perhaps. And so in relation to the water issue, we worked on raising awareness, lobbying commissioners for inclusion of water for injection in injecting packs, and removing the prescription-only medicine status from water ampules, which means that you're not allowed to break individual water ampules up to put them into injection packs. And I know this is all very sort of minutiae of detail, but that's what engaging with policy can be like. But we also worked with exchange supplies to develop a street injecting pack for people who were rough sleeping, which included water in a leaflet, overhauling information about water risks. That instead of providing this sort of super sanitary advice, for example, always wash your hands, which can actually enact a structural violence because not a lot of people can necessarily action it. It can create more shame. Instead, what I'm interested in doing and been working on with people like organisations like Exchange Supplies is providing information on a hierarchy of risks. If you can't get hold of sterile water, what's the next best? If you have to choose between using water out of a toilet bowl or puddle water, what's the safest? And we've had lots of interesting discussions trying to work out what actually the answers to those things are. And another example, if I have time to get through it, is that you know, the reason why people were sorry, I just thought I saw a Time's Up message, but maybe not. The people were getting these infections because of these constraints, and then the infections were exacerbated by delays in accessing care, which is profoundly impacted by criminalisation. You know, women, for example, were understandably afraid of seeking care because of fear of social services being alerted, incredible stigmatisation, discrimination in hospital settings. But what I felt that was actionable now was this issue of people not getting their opiate substitution therapy in a timely manner. And this led to understandable fear of withdrawal amongst participants, their need to stockpile money and drugs before seeking care, and self-discharge with large unhealed wounds was unfortunately really common. So again, as with the water one, is trying to understand what's underpinning these policies, what's going on. And we found that opiate substitution therapy was not on hospital critical medicines list, which informs the clinicians of what medicines need to be prioritised. So what informs the critical medicines list? It's the specialist pharmacy service delayed and omitted medicines tool. And here we found that drugs used in substance dependence were all lumped together. There was no demarcation between opiates or benzos, for example, and that they were deemed to be low risk if they were omitted or delayed. So with release, we sent freedom of information requests to hospitals to ask for their hospital policies, look what was going on. It was shocking. I'm not going to go into that. I can do that later. But what we have managed to do, which I feel is a bit of a triumph, is to work with the specialist pharmacy service to reconvene the tool. So here you can see that there's been a demarcation now between different types of drugs used in substance dependence, and the risk has been much more emphasised, and hopefully that might have a small change on people's experience in hospital. We've also worked with people who inject drugs to develop an advocacy card, think of a helpline, and so there's a grant underway for an intervention to improve care for people who inject drugs in hospital settings. Okay, now I'm not going to talk about crack pipe provision, I just put it in there in case anyone's interested and wants to have a look at the slides. But I just want to close in thinking back to some of these questions that I think were highlighted by Adam at the start. You know, what is the purpose of drug policy? What is the problem that we should be addressing? And where are we locating the harm? Are we locating it in the drug, in the substance itself, or in the individual? And these questions are important, as how we view the problem and where we locate the harm will both influence how it manifests and how we intervene. And then just in relation to the medical model, I want to close with this quote from John Booth Davies, which says, "The more we treat drug problems as if they were the domain of inadequate, sick or helpless people," whoops, it's just gone, sorry. There we go. "The more people will prevent themselves within that framework, and the more we will produce and encounter drug users who fit that description." And just to say that I feel that small structural changes can be individually transformative, and that it's crucial to continue to work within constraints while advocating for broader based change. And references are there, and I'm happy to share the slides or anything else. Thank you.
Thanks so much, Magdalena. That was all really interesting, really useful to have some practical examples. So yes, please keep the questions coming in to Magdalena, all of the other panelists. And I'm going to hand over now to our next panelist, Neil Woods. So Neil Woods is the chair of the Law Enforcement Action Initiative in Europe. He's a former undercover police officer, and he is the author of Good Cop, Bad War and Drug Wars with J.S. Raphael. Neil.
Thanks, Adam. I feel quite honoured to be a part of this particular gang. I've learned a great deal from each one of these panellists, so I am indeed honoured. When we advocate to the public or to policymakers for an ethical, evidence-based drug policy, the problem we have is that we are up against long-established and ingrained narratives. Now, from my realm, I'm a former police officer. The message amongst police and security services and some politicians is that our punitive drug laws are needed in order to successfully fight organised crime, and that if we didn't have these punitive laws, organised crime would become more powerful without this attention. But nothing could be further from the truth. Organised crime was birthed by drug prohibition and is maintained in its power by these laws that we have. And this narrative that successful policy is about punitive action is one of the great barriers in preventing us from considering everything else that the other panelists are saying about treating people as individuals and treating this as a health issue. So in challenging this established narrative, we have to look at it and realise what is actually being said. We are trained all around the world. We are trained by whatever government it is, whatever police force, wherever you are, we are trained to see successful drug policy or successful drug policing in certain images which go into our newspapers and media. The image of people's doors being smashed in, people being arrested, the image of large amounts of drugs being seized or large numbers of people being arrested. But this never actually reduces crime, and there is no evidence that this reduces crime. And when we consider this, we have to see the difference, the fundamental difference between drug crime and other forms of crime. So, in simple terms, if a police officer arrests a house burglar, someone who breaks into houses and steals for a living, then the numbers of those crimes will go down because there are always a limited number of people who are willing to commit that kind of crime and who have the skills to do so. If the police arrest a drug dealer, crime goes up. Now, as part of the Law Enforcement Action Partnership, I speak with police all over the world, and police note very carefully that often when they have a successful operation and arrest drug dealers, violence goes up because there is a gap created in the market. Now, I'll give you an example from my own experience. I used to work undercover. So I used to infiltrate organised crime, drug dealing gangs, in order to gather evidence against them. For one particular operation in Northampton in the United Kingdom, the gang was one of the most notorious and vicious in certainly that I was aware of, called the Burger Bar Boys. Now, I spent 7 months of very dangerous and careful work infiltrating this gang and getting very close to the core 6 gangsters who were running the heroin and crack cocaine supply in that town. Now, after 7 months, a huge amount of time and effort and resources went into it. By the end of it, I had gathered evidence against 96 people. There was the 6 principal gangsters plus 90 people who were their support mechanism, their employees. And by the end of that time, I knew exactly where the supply routes were, who had the money, who was doing the deliveries. I knew everything. There was no one else to meet, no new phone numbers to get. So I was confident that at that 7-month mark, we could arrest and capture every single person involved in that town. And I was excited because to me, this could have been, this looked like a huge success. We would be able to shut down the whole drug supply in that town and maybe protect vulnerable people. That was my thinking at the time. There were 5 different police forces, hundreds of different police involved in all of these arrests. 2 weeks later, after the dust had settled, I received a phone call from the intelligence expert from that operation. And they said to me, well, we managed to interrupt the drug supply in Northampton for a full 2 hours. 7 months of work, I almost died twice, 96 people arrested and hundreds of police involved to interrupt the drug supply for 2 hours. Now, you can imagine the rival gang receiving the phone call, hearing the news about what the police have done. They would have been ecstatic because they knew there was a sudden market opportunity to make an enormous amount of money. So wherever you are in the world, the police are really good at catching drug dealers, really good. But that is part of the problem. When the market gap is created, violence tends to increase because police never reduce the size of the market, never. But we do change the shape of it. And over time, that shape becomes more and more dangerous. The violence in the drug markets is caused by policing. But there is another consideration here as well. Where a gap in the market is created, it tends to be the more successful organised crime groups who are able to take up that opportunity. So an organised crime group grows in their influence by police action. Now, the secondary effect of that is that where a gang or organised crime group has an increased share in the market, their wealth increases, which means they have more disposable income to invest in corruption. So the action of policing makes corruption more likely. And we see this play out all over the world at each level in the market. It is, if you look at Mexico, for example, there was a time when there were 20 different cartels. Now there are only 3, and each one of those cartels is much wealthier and able to corrupt not just local law enforcement, but also in state actors. Guinea-Bissau in West Africa, for example, is now considered a narco state controlled by international drug cartels because it's a route, the cocaine route, into West Africa and into Europe. This corruption is only going in one direction, and it is accelerated by police action. So in advocating an ethical drug policy, a health-based drug policy, it's helpful to try and encourage honesty in this regard, because there is a lot of dishonesty. We are told what success looks like. We are told that the arrests and seizures reduce crime, and they do not. They do not. So when we call for evidence, we need to consider what different politicians listen to. And whereas drug policy reform is a non-partisan issue, we do have to consider who is listening to what parts of the argument. As a police officer, as a young police officer, I didn't care so much about liberty. I believed in looking after people's security. And this liberty versus security issue is a key part of the discussion for certain political demographics. But we now have a situation where clearly the pursuit of individual liberty is the path to greater security, because it is the taking away of individual liberty that prohibition has created that has led to the huge power of organised crime. And so I appreciate I've only tackled this from a fairly narrow perspective, a policing perspective, but the points that I've just raised are often missing from the discussion of international drug policy. Thank you.
That's great. Thanks very much, Neil. I think it's hard to argue with that. Unfortunately, people do. So now I'll hand you over to Nuno, our next panelist, Dr. Nuno Capaz, who's the Vice Chair of the Lisbon Dissuasion Commission, who has worked in the dissuasion commissions in Portugal since the country decriminalised the possession of drugs in 2001.
Well, good afternoon, everyone. Thank you very much, Adam, for inviting me for this webinar. It's good to see some familiar faces after all these months semi-locked in. So I want to pick up a little bit where some of the speakers before me talked, and the basic question that Adam proposed to all of us regarding what should be an ethic drug policy. And I would also try to address more generally what I mean, or what we should think about when we talk about drug policy. For us in Portugal, when we decided to change drug policy back in 2000, 1999 and 2000, we had the constraint of the UN conventions. One of the, basically the only limit that were established to our new drug policy was that we should be in compliance with the UN conventions that were established too long ago. Maybe they should change in some way or whatnot, but I'm not getting into that. I'm just stating how it was in Portugal. We had these constraints, we had to work inside those. So normally people know the Portuguese drug policy because we decided to decriminalize all drug usage regardless of the substance. We thought that would be what we consider to be an ethical approach, because quite honestly, well, the substance itself are not heavy or light or more dangerous than others. Some can be more riskier, but it all depends on the way you interact with them or the way you use them. And so that's why we decided to decriminalize all drug usage, and also because decriminalizing for us didn't have anything to do with regulating or with legalizing drug usage. It's still illegal, again, under the UN conventions. It's still illegal. The only difference is that it's no longer considered a criminal offense, regardless of the substance. And what that basically allowed us to do was to remove drug users from the criminal and the judicial system and into the healthcare system. If it's considered an administrative offense, you don't apply criminal sanctions. You do not need a criminal justice system to intervene in those sort of situations. Just as an example, and because time is really short, in Portugal, bearing in your possession any sort of illicit substance for personal usage, it's exactly the same thing as driving without the seatbelt. It's illegal. There are some consequences, but not criminal consequences. You don't get to go to court because of that. And what that allowed us to do, because we decided to go a step further and improve a little bit on what we were trying to do with removing people from the criminal and judicial system, we decided to create specific structures under the Ministry of Health to deal with those procedures. So what happens in Portugal, it's that it's still considered an illegal activity. It's still forbidden. You cannot use any sort of illicit substance in Portugal. The difference is that when you're caught, you're automatically diverted into the healthcare system and into the and not the criminal system and the court system. And that allows us to, well, remove the stigma associated with criminalization, criminal records, and so on, convictions, things like that. It doesn't solve basically any problem apart from the criminal record issue. And this is where I would like to, maybe it's a topic that we can discuss a little further, because one other question that was asked was, how can we address policymakers when advocating for a drug policy change? And I think we should be really careful about what we are saying. If we are saying that we want to change our drug policy, or if you want to change some isolated measures about what you already have in place and what should be considered a drug policy. What we did in Portugal was a very holistic approach, a very comprehensive approach. Basically, we changed everything. We concentrated our efforts in terms of drug issues under a single structure under the Ministry of Health. And that's one of the reasons why I think Portugal is considered in many ways as a success in terms of drug policy. It's because we decided to change precisely that, the drug policy, and not some isolated measures. Yes, there was some isolated measures that were taken because you need to move forward with the policy. It's a set of different things that need to be changed and that need to be in tune, but that's still going on. We changed the drug policy back in 2001, and from then on, we've been changing small things or increasing some things or diminishing some other things, because the problem it's an evolving one. And I think while engaging policymakers, we should stress this point, because an isolated measure might have some results immediately regarding one specific problem, but will not have some long-term effects in the general problem. And to do that, you need to change the drug policy in a more comprehensive way. We were lucky that we had that opportunity back in 2001, but we were also brave enough to stand by it. I've seen all throughout these years working in drug policy, and a little bit also in terms of international wise, I've seen a lot of countries taking steps to change their drug policy. But in the end, it all gets decided at the political office, and normally they would not go for the holistic approach. They will normally tend to cherry pick the nice looking ones for the next election. And those are the ones that are going to take effect in 2-3 years. Long-term effects, you need to have a stronger drug policy, a deeper drug policy change than just some isolated measures. I would also like to address, and it's always a pleasure to talk after Professor David Nutt, because I can't keep a straight face while mentioning evidence-based policies, because, well, if it's been forbidden all the and if it's been banned all the investigation in all these substances, where are we supposed to get the evidence-based studies? If people are not allowed to conduct studies and to experiment stuff, how are politicians going to base their drug policy in evidence-based things? So I think it's a bit distracting, this evidence-based debate, because, well, politicians don't work like that. Politicians don't work on evidence-based programs. They work much better in poll-based programs. And so I think, yes, I think we should have evidence-based, but we should first allow people to produce that evidence, right? Professor Nutt is always very open about the difficulty in researching LSD and magic mushrooms and things like that. And he's right. Is right. How can you support a change in the law if you don't have evidence produced to support their own law? So it's, in the end, it all comes down to political issues and to a political debate that it's normally not very centered in health perspective because of all the moral issues associated with drug usage. In Portugal, we decided when we went for the change in the law, we had that constraint of the UN conventions on how further can we move things around, or how further can we go with regulating some substances and things like that. We didn't do any because the UN conventions didn't allow us to do that. What we also tried to do, and I think that's one of the reasons why it worked for us, was that we were very pragmatic about what we were proposing, and the feasibility of those measures was basically We just ask in every change that we proposed, is this doable? Is this going to be taking effect in real life by a police officer on the street when it comes around someone using drugs or not? And that pragmatic approach, I think it's much more valuable nowadays than an evidence-based one, because the evidence-based one, it's not strong enough, or it's not deep enough. So I think we should be pragmatic about drug issues. I think we should be pragmatic about drug policy. And I think we should bear in mind that an ethical drug policy is the one that it's centered on the people and not on the substances. For example, when you schedule substances, you are completely disregarding that different people use the same substance for different reasons and with different risks, or with different harms associated with it. And just the prohibition system, for me, it's very centered on the substances and not so much on the people that uses those substances. And I think that's elementally wrong, because policies should be made to improve the quality of life of the people that they are going to be applied to. Thank you.
Thanks so much, Nuno. That was all fascinating. If anyone has any questions for Nuno, or indeed for any of the other speakers, you can still enter them at the Q&A in the bottom. We're getting some really interesting questions in. So thank you to everyone who has already submitted one. So now it's my pleasure to hand over to Prun. He's the medical director in Live, which is a national drug treatment service in the UK, and he is also a former member of the UK Home Office Library Council for the Misuse of Drugs.
Thank you very much, Adam, and thank you for inviting me to speak here amongst this group of amazing people. It's a real honor. You posed some questions, and I'm going to try and stick to those. And the first one was, what does ethical drug policy look like? I've tried to answer your questions through the lens of treatment, but it always comes back to policy, actually. Treatment is just often symptomatic of the consequences of policy. And when we're talking about drug policy, depending where you are in the world, sometimes those consequences can be severe for people. So the way I think about it is an ethical drug policy is one that promotes human rights. Now, that could be insofar as liberty for some people, and in some areas all the way right through to life and harm and the right to life in some other areas. I think a policy that doesn't medicalize or criminalize non-problematic drug use is something which we sometimes don't see. And certainly when we see policies that lead to a differential treatment of certain groups, be they minority groups or people that are already experiencing health inequalities, I would wonder about those particular policies. But when we're looking at treatment, I was fascinated by what Magdalena had to say about the system and the structures. And actually, you don't have to scratch too far under the surface to see that the treatment sector, the treatment for drug problems, problematic drug use, where people have issues with that, where they do need to seek treatment, are just a very, very small part of the wider system that people who use drugs and people who have problems with drugs find themselves in. When, as a treatment provider, we have to think about what are the core principles that we want to promote for people, and that is treatment. We should be trying to make it as easy as possible for people to get access to evidence-based interventions, and there are evidence-based interventions at our disposal. So, treatment should be easy to access. It should be easy to get in. It should be easy to stay in. But if drug policies are pointed in a certain direction, that can make that difficult. So it can be hard enough to actually seek treatment, but it could be even harder if you're also first deemed a criminal before you seek treatment. And I'm not saying that everybody who has a drug problem has a medical problem, far from it, but I do think it can be difficult. And I do think the additional stigma of being criminalized could only really be a barrier. What Professor Nutt was talking about around the opportunities lost around the approach to drugs, I agree wholeheartedly. If we're talking about new interventions and new opportunities for people, therapeutic interventions, promotion of research and exploring therapeutic potential of treatments is curtailed with very restrictive drug policies. An example of that might be, recent statistics in the UK show greater than some of the highest levels of death associated with cocaine use on record. Yet the research into cocaine and in fact the use of cocaine as potentially a therapeutic agent is almost non-existent, and there are some real issues with that. Some of the challenges I think are significant, and one of those is, a lot of this has been mentioned before, but one of the things is that this narrative of the immorality of drug use and has been around for so long that it's come to be accepted as normal. And that's a massive challenge. From a treatment perspective, that does lead to problems. If a group of people who need treatment are automatically stigmatized for their behavior, then the requirement or the political pressure to actually invest in treatment for people is far less. It's much easier to disinvest in treatment for people with drug problems. That's an issue. And generally, I think we tend not to take a systemic and a structural approach to looking at problems. And just one of the other questions, Adam, you asked was around, what can we do to challenge the status quo? And that's a really difficult one. But I think I could answer that from what can I do? And I think the first thing is we can only sort of look at what we can do ourselves first, what we can change first. And that is to check the world around you first, check your own systems. So as a medical director and a treatment provider, one of the things I can do is to work with my colleagues to look at our own policies, our own treatment policies, for example. Are they, do they do what I've just said that we should be supporting? Are they least restrictive? Do they promote liberty? Do they promote autonomy? Do they promote choice? Do they enable people to feel in control of their treatment? Do they contain punitive practices that, a clinician may not see, that somebody using the service is able to challenge and change? So you can make those changes yourself first. What are employment policies like? And this can be for any organization. Does your employment policy actually exclude or potentially bias people who may use drugs or have a history of using drugs? As experts, we have a role to play. Often we find that I think we need to be bold and speak up for what is right. Often we struggle to engage in these topics because there isn't evidence. So there's no evidence that there won't be harm caused by certain things. Whereas where there's no evidence, and there's plenty of evidence that there's harm caused by policies that haven't worked, I think we need to challenge those things. We often hear about, and while I talk on the one hand about disinvestment, and that is a real thing, and treatment services need to be invested in, it's not the only thing. And if I was given the choice tomorrow to say, would we have a more ethical drug policy, I'm not going to say necessarily health-related drug policy, but an ethical drug policy, a human rights-based drug policy, over more investment in treatment services, I would choose the former because I feel that would actually make the biggest difference. And just to finish, I think how to make changes when these are such deep problems. Well, I think you have to remain open-minded. You have to also understand that people's experience and what they've heard around drug use and drug policy can all be very, very different. And to be compassionate and understanding about people's ideas and to listen. And that's what I've had to do. And that's been really helpful. I've learned a lot from speaking to a lot of people, some people on this call and other colleagues, and then have conversations yourself, one person at a time. I'll give you an example. When I was growing up, I had a very fixed view on drug use and what that meant and exactly the morality around drug use. And I quickly learned that that wasn't the reality of the situation. I didn't want that to be the case for my children. And I spoke to my daughter, who challenged the drug education that was being peddled in her school, which she challenged as being punitive and discriminatory, and she managed to get it stopped and paused. I asked her how I should, if there's any key messages I should have, and she said to me, make sure that you communicate that nice people use drugs, and support is the right way, not punishment, and that's the approach that we should take. And I think that is the approach that we must take for the future, to change people's opinions one person at a time. Hand over back to you, Adam. Thank you.
Thanks. That was great. If we could get the panelists now to turn their cameras back on, and we're going to open up the floor to Q&A. So Emily has kindly been collating the questions that you've been sending in, and is going to direct them to the panel. It's not too late to submit a question, please enter them in the Q&A function at the bottom.
Right, so I have been trying to collate some questions. I've tried to pull them together. Some are relevant for specific people, and then there are some wider ones. So I'll try asking the questions to specific people first, and then we can go into the broader ones. So a question for Anne from Raffaella Rigoni, which is, I would like to ask your opinion about how we can assure ethical drug policies in a scenario where drug legalization or regulation increasingly has strong ties with commercial interests, thinking, for instance, about potpreneurs.
Thanks, Emily, and thanks, Raffaella. I've never heard the term potpreneurs, actually, but it's an interesting one. It is a really important question, and I think for those of us who've been, advocating for drug policy reform, and increasingly the discussion around legal regulation has become more mainstream in the discussion of drug policy reform. Of course, we've suddenly seen the potential of commercialization and commercial interests coming into this space and basically, further entrenching some of the structural inequalities that we see under prohibition. So it is a very valid and live question. To this point, IDPC actually produced, and we released this in September, our first ever principles for the legal regulation of cannabis, which really tries to address this question and to basically, equip advocates around drug policy on how to have this conversation, because it is coming. This is a reality. Cannabis markets are opening up for medical, for recreational use. Commercial interests will be involved. And, we have a sort of, once in a lifetime opportunity to shape this market as it happens. In a way, to include traditional farmers, to include those who have been involved in the illicit market, and obviously their criminalization may create a problem for that involvement, so that also needs to be addressed. But how can they be part of the discussion now that something they've been involved in and criminalized for is actually moving into the legal space? And from a social justice perspective, it's really important that they are also at the table and it's not entirely driven by commercial interests. So yeah, I hope Emily can share the IDPC principles document in the chat. And
I've just done that, so hopefully people should be able to see them.
And happy to have this conversation further, but it's a very live and important debate.
So I have another question for Anne, but I think it leads into a broader question that other people please feel free to kind of chip in. So the specific question for Anne is it's from Martin Jelsma, and it's the United Nations Drug Conventions were negotiated before indigenous rights were firmly established. The UN drug control regime condemns and criminalizes indigenous use of cannabis, coca, and opium, creating a legal conflict under international law. What paths are there available to indigenous peoples to reclaim their rights? And before Anne answers that, I just want to say that there's another question which kind of leads into this idea of diversity and making sure lots of different voices are heard in this. So perhaps once Anne has spoken, maybe other people could contribute to how we can get a wide range of voices heard in drug law reform?
Thanks, Emily. It's a really important question. And I think, we have not in drug policy reform in the wider discussion talked enough about the impact on Indigenous peoples and how their rights have been deeply violated by international drug control. So there are several paths to address or redress the issue of the violation of Indigenous people's rights. I think at the UN level, this is probably where this would happen. So there is the UN Permanent Forum on Indigenous Rights, where it has already been expressed that traditional use of coca needs to be recognized, and that there needs to be a change to the 1961 Convention, which actually has an obligation for countries to abolish the use of coca. Traditional use of coca. Several years ago, some of you who follow this may recall Bolivia has given another path where they withdrew from the 1961 Convention and re-acceded with a reservation on coca chewing. It should also be discussed perhaps again at the Human Rights Council. The High Commissioner for Human Rights has also expressed a concern about the violation of Indigenous rights. And several member states in the Bolivia case, by the way, objected to Bolivia's reascension to the 1961 treaty with this reservation, including the United Kingdom, which is incredibly problematic, and the UK should withdraw that objection, for example, to Bolivia's move to have this reservation on the 61 Convention and protect Indigenous rights.
Thank you, Anne. Do any of the other panelists have any thoughts and contributions about the kinds of people, the kinds of voices we need, and how we can engage different voices within drug law reform discussions? No. Okay. I mean, I think that's a really, really important.
Yeah, I think Prun popped his hand up. I think Prun had something to say there. Sorry.
It's worth noting that I know there are two academics in the UK, Rebecca Askew and Melissa Bone, who are doing research funded by the Economic and Social Research Council, which is exactly about interviewing people who use drugs and asking them what they think and how they can contribute. So it's recognized that these are really important narratives. So a question for Magdalena from Matt Southwell, which says, thank you for a really fascinating exploration about ethical drug policy from different perspectives, from the macro to the micro. Thank you for your amazing work, Magdalena, that provides such detailed analysis of the policy barriers faced by people who inject drugs. How do you think drug user rights movements can prioritize and target our advocacy to achieve the types of small changes that could offer the incremental wins to our community?
Thanks, Matt. Thank you for your kind words, and also, your important involvement in drug user movements and advocacy. Perhaps you probably even know the answer to that better than I would, but I think it's about identifying what are the issues and I think perhaps digging a little deeper to understand what are some of the structural obstacles. So, for example, if we think about opiate substitution therapy provision in hospital, definitely an issue is the punitive approach of some clinicians and some nurses, but it could be left at that. And I think it's also important to think about, well, what are the clinical guidelines that they have to follow? What might be some of the structural issues? Because there are good clinicians, there are great nurses as well. There are people that want to be able to provide help, and sometimes they are stymied by policy barriers. For example, the water for injection, not being able to divide up the ampules. It takes a little bit of digging to think beyond the most obvious explanation, which is just about budgetary constraints, and look at some of the other obstacles that are creating barriers. And so I think for drug user communities. It's about identifying, you know, where the barriers are, what the problems are, and working with others, with people who are working in policy, with myself, with people like Jenny Scott, who's works in pharmacy practice, to really dig in and unpick what some of the problems are, and then advocate for change and advocate for, you know, play the game. Say, you know, how much money this is costing, not, you know, barriers to care, people not coming in. It means they're going to be, you know, hospitalized much longer. It's going to cost the NHS much more. You know, people injecting saliva, they're going to end up costing, you know, millions to the hospital care, whereas, you know, play the game. Speak, you know, I wish that we could just use human rights as our angle, but often there are very, very good monetary reasons why things need to be changed, and that's often what can get people's attention.
That's great. I wondered whether Prun had something to contribute either to this one or actually the previous question.
Sorry, yeah, I mean, I think there's a real gap in the UK, actually, in terms of the voice of the community, and sometimes that's, and I think that's probably a real detriment to anything when we talk around drug policy, to drug treatment, to everything, because you don't actually hear the perspective of people. If the voice of the community is then linked to, say, treatment services, which it has been in, say, the last number of years, that then medicalizes the issue around drug policy, as opposed to the vast majority of people who use drugs without any issue whatsoever. So I think it's a really important point. And I think most clinicians, again, speaking from a treatment perspective, should be in a position where they welcome that. They should be in a position where the person coming to their door is informed, understands what their rights are, understand what treatment should look like and should be like. And I think most good clinicians would actually really welcome that.
Thank you very much.
Can I just add something? I mean, I think you made a really important point about the importance of hearing voices of the community. And in the UK, we have a huge barrier in that there's no proper funding allocated for communities of people who use and inject drugs. And for example, in Australia, you have state funding for user organisations, so they're able to advocate around broader issues, broader human rights-based issues, even though they may be funded under a hepatitis C or a HIV prevention remit. And here it is very localised, it's associated with treatment, and often in a very tokenistic manner. So I think there needs to be real investment in supporting drug user organisations and getting them proper funding and proper engagement and involvement of all levels of policy decisions, and for researchers to more actively work with communities of people who inject drugs as equal partners.
Thank you. So now I have a question for Neil from Anton Basenko. Have there been any changes in policy and practice of the police that have happened as a result of the experience of counteracting the drug trade that you talked about? And how did it influence the budgets of the police? He goes on to say, because unfortunately in Ukraine, as a low middle income country, where different law enforcers and ministries are always fighting for state budget, police are always trying to use the fight for drugs as a way to reinforce their budget.
Yeah, that's a really good question. And this is a problem we have all over the world, that police use the drug war to justify getting more resources. And the biggest example perhaps of this is in the United States, where the militarization of police, the increasing militarization of police is being driven by drug war rhetoric. But we do have interesting changes happening amongst the police community around the world, and most notably perhaps here in the United Kingdom, where actually much of drug policy reform is being led by the police. And often the police are completely ahead of the politics in that regard. So, for example, one police force in Cleveland, which is in the north of England, the person in control of the budget, the Police and Crime Commissioner, has been using policing money, actual policing resources, to pay for heroin-assisted treatment. So, to be clear, that means they are paying for heroin, clean medical grade heroin, to be prescribed to the most problematic heroin consumers in their community. And this is done by a dedicated clinic. So there is significant resources being put into this. Now, aside from the fact that these are vulnerable people who should be looked after wherever the funds come from, the thinking behind the police and the messaging to politicians and the public about this is that actually it reduces crime. And it also, significantly in the United Kingdom at the moment, it reduces the exploitation of children. Now I'll explain. The most problematic of heroin consumers in the United Kingdom, and this is the same at most parts of the world wherever the data is, the most problematic heroin consumers consume the largest amount of heroin. So in the UK, the most problematic 10% consume 50% of the market's heroin, 50%. So the most problematic people are using significantly more than others. Now, if you only prescribe to that 10% and give them the drugs for free, then you are taking away half of the market away from organised crime. Now, at the moment in the UK, organised crime are exploiting children to sell those drugs. So the policing impact is you actually protect children and reduce the power of organised crime by taking their money away from them. And if organised crime has less money, they have less money to corrupt the system. They have less money to invest in other forms of criminality. And actually, the crime savings, the reduction in crime, can be very significant indeed, as there are clear examples in Switzerland, for example, where they have had a very long established heroin-assisted treatment program since about 1994. So it's about challenging that existing rhetoric, that sort of standard jingoistic war cry from the police, that actually if you are really and genuinely interested in reducing crime, then you should use your resources to best effect. Now, unfortunately, this is a very difficult argument to have, because in many jurisdictions, this will mean that resources will eventually get moved away from policing and into health. And that's a very difficult thing to sell to many senior police. I know, I appreciate that's very difficult. However, that really is the outcome that we need. We need less policing and we need more health. It really is that simple. But the advocacy to police, I can appreciate, Anton, where you are, and in many places is very difficult.
Thank you very much. So now I have a question. I think I'm going to address this to Nuno. So there's quite a specific question about Portuguese policy. And the question, it's from Lee Collingham. It says, I know it's still illegal, but are there financial penalties to any of the misdemeanors in Portugal?
Yes, there are some sanctions that can be applied to drug users that are caught in the possession of illicit substances. And basically the list of sanctions are exactly the same as the driving offenses, meaning financial fine or community service or regular presentation at a service designated by the Dissuasion Commission. The originality about the Portuguese system is that these sanctions are decided by a panel that works under the Ministry of Health. And so basically what we do is we do an assessment of the risk level of the drug user, and bearing in mind that assessment, we decide which sanction, if any, should be applied to that drug user in specific. And normally the projected outcome is to have some sort of benefit in the life of that person in the cases where they can benefit from it.
Thank you very much. And then I have also, there's a specific question for Professor David Nutt from Elsa, who's a street nurse in Reykjavik. And the question is, are there safe injection rooms in the UK at present? And are health workers working there? And is it classified as healthcare?
Well, the answer is there is a van in Glasgow, which is run by a single solitary enthusiast and visionary, and we are trying to get safe injecting rooms. But we have a government that is even more opposed to rational drug policy than the previous one. So it's not yet, sadly. We are definitely lagging behind many countries, but drug science is working to try to set up one, just to prove that the world doesn't end when you do have a drug consumption room.
Thank you very much. No, so we're coming towards the end, but I just wondered, because there was another question, which was, it's quite specific. I think it's about how can countries work together in Europe to change drug policy. But I think we could broaden that out and say, how can we work together to change drug policy, whether that's in one country or whether that's in a region like Europe or broader than that? So does anyone have any answers to that?
I think conferences like this probably help.
I think all we can do is share our own experiences and eventually try to come up with solutions for different problems that people have. It's I've been fortunate enough to attend these sort of conferences, both in person and online. And I think it's important to share a little bit of our experience to people that are facing similar problems. Although in the end, it might not have a dramatic effect in terms of drug policy, but at least it's we keep talking about it and eventually things will change, I guess.
Thank you. Anne?
Yeah, I mean, I think it's, drug policies are changing also. I think it's important to recognize that, things are shifting, and obviously many of you will have been watching the US elections very closely, but also in the background, a fair number of states have made great advancements in their drug policies, which would have been unthinkable, even 5 years ago, perhaps, and definitely 10 years ago. More countries are looking towards decriminalization. We're seeing what's happening with cannabis, and of course that is that, there are also some challenges that will be raised there, but the weight of I think all the collective pushing and advocacy and broadening out the discussion to include academics and law enforcement and treatment providers, and ensuring that the voices of the most affected communities are front and center of this discussion, that they lead this change, I think is making a difference. So, and I think it's about collectivizing, IDPC is a global network that is, by design, because, being connected and pushing in the same direction is incredibly important. So yeah, I think things are happening, and of course, yeah, more outreach to new people and bringing them into this movement is important.
Thank you. So I know Prun had a comment. Did you also, Neil, have a comment?
Yeah, but after Prun.
Prun.
Yeah, thanks, Neil. I just
very quickly. So we've come to the scheduled end of the webinar, but we do have time for a couple more questions. But I just wanted to quickly say, if you do need to leave now, thank you so much for coming, and I'm sure I can thank on behalf of the other speakers and organisers at the conference today. It's been a series of really great events made by you coming, so thank you so much. And again to the panel, I'm posting the link to the film again in the chat, which will be in 15 minutes. There we go.
Bye, David.
We've still got time for a few. Back over to Prun.
So Prun, yes.
Yeah, I mean, I agree that things like this are essential. Connection is really, really important. And some of the smallest changes that you can make actually will make a difference. I mean, some of the work that Magdalena was doing, for example, working with clinicians, might have the ripple effects of things like that can be really significant, opening the eyes of systems like health systems. People don't have access, forget sort of access to drug treatment. People don't have access to primary care, to basic treatment, to basic wound care and other things. So making some of those small changes can have ripple effects. But I do think fundamentally, we do need to look at the systems, not the surface, not the consequences of things, but the systems, and actually really shine a light on what's going on there and start sort of raising some of those things to the fore. And also maybe changing our sense of time around what we're expecting. What we do now and what we continue to do now might have consequences in years hence, and we just need to kind of persist and keep going. I think that's really important because it can be easy to lose hope sometimes. So yeah, that's my point.
Thank you. Neil?
Yeah, I mean, I agree, and I'd just like to echo everything that's just been said. Like Anne said, I think the growth of the IDPC is very important, and the NGOs are more connected. But I think more fundamentally, I think it's helpful if we all see ourselves as part of a movement. Policy change for social justice issues don't generally come from political leadership. They come from social movement, and we are a movement. And if you're listening to this and you agree with us all that we need reform, then you're part of that movement. We all have our responsibility to do what we can in any small way that we can, whether that's just engagement on social media, persuading our friends or parents or whoever it is that change needs to happen. It's the responsibility of every individual who believes in this, because this is a fight for human rights, and we should see it that way, and we're all part of a big gang.
Thank you, love that. Right now, so I've got we've got a few more little questions, but I thought one that comes from Tabitha, it kind of feeds into something that Prun was saying earlier, but how can we change the narratives and stories surrounding these issues while some authorities and professionals do not actually admit that there's a problem? Anyone? I mean, like it very much, I was thinking about what Prun was saying about his daughter and the drugs education, but I wonder if anyone else has any thoughts.
I think, I mean, just from my perspective, it's about bringing the stories to light. I mean, how can people perceive that there's no problem when they hear narratives like some of the ones that I've shared? And I think that actually, you know, it's a little plug for qualitative research, but also for user involvement and the voice of the affected community. That those stories are incredibly powerful. And it's really important to humanize and to provide some narratives of what is going on behind the numbers, because we can sort of cut off to numbers. They don't feel real. You know, they may illustrate the extent of a problem, but hearing the human story and the desperation that people are feeling, hopefully may move some to act. And I think that, you know, there's been a whole movement in narrative-based medicine and clinicians engaging more with people's stories. But again, you know, this is a structural and systemic problem in terms of funding cuts. GPs only been allowed to spend 5 minutes with each patient. I mean, there's all sorts of issues going on here. But I think, you know, let's think about trying to bring some of those narratives. And I really loved what Neil said. You know, it made me feel a bit emotional that we are all part of a movement and really and learning from each other, you know, and discovering what it works from different perspectives, as well as some of the wonderful gains that we have seen in the last couple of days in Oregon, for example, and other places. Thanks.
Thank you very much. So I feel like we've covered most of the questions. So I wonder if anyone has any kind of concluding thoughts. Adam.
Hello, unexpected curveball. I think as a final thought, I can just say once again, thank you so much to everyone for coming. I think we can all agree this has been really interesting and really useful. I guess I'm just going to use this as another opportunity to plug the film, which I've done about 7 times. The link is in the chat if anyone does want. And any opportunities for using that film and trying to spread the good word further afield. If anyone has any ideas, then please do let me know. We're going to send around a feedback form after the webinar is finished on there. It's my email address. And so do get in touch if you've got any ideas. So I guess we can probably draw to a close. Thank you so much again to everyone, to all the panelists, everyone who's in the film, and we'll see some of you in the live chat on YouTube soon, I'm sure. Great. Thanks, everyone.
Thank you.
Thank you. Thanks all. Good to see you.